Hello, everyone, and welcome to the monthly National Action Alliance for Patient and Workforce Safety webinar. We're thrilled to have all of you joining us today live, or if you're listening to the recording later. And today, as many of you probably already know, is also World Patient Safety Day. So great opportunity for us to have this monthly webinar on this very important day. Today's topic will be advancing patient safety through diagnostic safety. A few quick housekeeping instructions before we get started. The webinar is being recorded and will be available for viewing on the National Action Alliance website in the future. Please use the chat function throughout the webinar to post questions or thoughts that you may have regarding the presentations or any of the questions that we'll pose to all of you. Closed captioning is available, as you can see from the picture on the slide instructing you how to access that if needed. So with that, we want to just start off a little bit thinking about World Patient Safety Day 2024. And I was thinking about this as I was getting ready for today's webinar, and I forgot to mention my name, sorry. Fran Griffin, I'm the moderator for today's session. I'm a patient safety consultant working with the National Action Alliance team. And I started working on patient safety quite a while ago in the mid-90s, and we didn't have a World Patient Safety Day back then. In fact, sometimes it was difficult to get people to talk about patient safety. Not everybody was ready to think about that dimension of quality. And we were all thrilled in 1999 when the Institute of Medicine report came out to Err is Human, that those of you who've been working on this for a while will certainly remember. Those of you who are newer to the field, if you've never looked at it, I would encourage you to do so, because it got quite a bit of attention at the time and really helped propel the patient safety movement forward to where it is today. And that was, again, the Institute of Medicine report 1999 to Err is Human, which had a follow-up report on crossing the quality chasm that got into the actual strategies. And it's hard to believe it's been 25 years since that happened. Much has transpired over that time. We've made some wonderful forward strides in patient safety and incorporating workforce safety to that. And it's so much better than it was when I think back to the mid-90s. And it's now part of organizational strategies and talked about, and we have patient safety officers and strategies. We still have a ways to go, though. So as we commemorate this day, we think back on how much has been accomplished over the past 25 to 30 years in the patient safety movement, and yet how much we still have to do. Certainly the pandemic set things back a little bit, and now we are really trying to move forward with getting the acceleration back on that. So thank you all for joining us today and for all the work you're doing on patient and workforce safety. And I like the theme that we have for improving diagnosis for patient safety on today's World Patient Safety Day. Get it right and make it safe. It's a great way for us to be thinking about it. So on this global public health day, as people are talking around patient safety around the world, we're going to talk about diagnostic safety. So as many of you know, diagnostic errors are common, they are costly, and they have a great deal of impact on patient safety. Just if you look at some of the data, and this is just a slice of it, 1 in 20 adults experience a diagnostic error in the outpatient setting every year. There are about 250,000 harmful diagnostic errors in US hospitals every year. And like we saw in the 1999 report, it's probably even greater than that. This is just based on what we know. And 79% of those diagnostic errors have relationships to the patient-clinician encounter, communication often being a big part of that. So there are tools and strategies that can be used to reduce and prevent diagnostic errors. And that will be the framing for our discussion today. So we have a question that, before we get to the question, the tools that we're going to really be emphasizing today from AHRQ. So Team Steps, many of you will probably already use this. Team Steps Diagnostic Improvement course is available. Calibrate DX, a self-evaluation tool. Measure DX, which has resources to detect, analyze, and learn from diagnostic events. And a toolkit for engaging patients to improve diagnostic safety. So the toolkits will be addressed in today's presentation, and as you can see, there's a link at the bottom of the slide where you can access all of these free tools at any time. So to our questions to run on today. So when we put today's session together, what we thought about was, what are the tools and resources available to help organizations prevent diagnostic error? And what strategies can healthcare organizations implement to prevent diagnostic errors? So that is the framing for our discussion today. And we have a question we'd like all of you to think about as we go through today's presentations. So this is the question we're going to tee up now, and we will revisit this later in the webinar. We'd like to know what type of diagnostic errors are the top priority in your organization. And maybe that will change based on what you hear from our great speakers today. So I'd like to introduce our first two speakers for today. First, we have Dr. Kelly Smith. So Dr. Smith is co-director of the AHRQ-funded Patient-Partnered Diagnostic Center of Excellence, working alongside patients to reduce diagnostic errors. Dr. Smith co-led the design and evaluation of the Patient DX Toolkit, which you'll be hearing about, holds the Michael Guerin Chair in Patient-Oriented Research, and serves as Chief Scientific Officer at Michael Guerin Hospital in Toronto, Canada, and as an Associate Professor at the University of Toronto. We also have with us today Dr. Hardeep Singh, a professor of medicine at the Center for Innovations in Quality, Effectiveness, and Safety, based at the Michael E. DeBakey VA Medical Center and Baylor College of Medicine in Houston. He leads a portfolio of multidisciplinary patient safety research related to measurement and reduction of diagnostic errors that have informed several national and international patient safety initiatives and policy reports. He has received several prestigious awards, including the 2021 John M. Eisenberg Patient Safety and Quality Award for Individual Lifetime Achievement. So it is my pleasure at this time to turn it over to Dr. Smith and Dr. Singh.
Great. Thank you so much, Fran, for introducing us. And I'm here to talk about the toolkit for engaging patients to improve diagnostic safety. We lovingly call this Patient DX to continue the theme of all of the Agency for Healthcare Research and Quality tools that we created under this task order. So next slide, please. So one of the key things we've learned from our patients and our family members is about listening and the importance of listening to get a safe, timely, accurate, and well-communicated diagnosis. So just listen to your patient. He's telling you the diagnosis. It was one of the phrases that was given out by Sir William Osler early in the 1900s, and things haven't really changed that much. This quote is such an impactful one for patients, for family members, and for clinicians when they're hearing about listening as a key attribute to the diagnostic process. From a patient perspective, listening is an often essential and underutilized tool in the diagnostic process. And our toolkit aimed to really bridge the gap in communication, that 79% number that we saw Fran present earlier about that gap in communication in the primary care encounter. And so our toolkit really aimed to bridge that gap with the goal of enhancing collaborative communication between patients and their clinician, either their doctor or nurse practitioner, in a clinical encounter. Next slide, please. The work of the toolkit was really underpinned by a very large environmental scan, and we talked to lots of different patients and family members, clinicians, both specialty clinicians, primary care clinicians, individuals who worked in the ambulatory setting as well as the hospital setting. And we asked a big question: what can patient engagement do to improve diagnostic safety? How can we achieve diagnostic safety in an encounter? And what patients were telling us was around listening, was around being interrupted, was around, I want to be heard, I want to feel seen. And what clinicians were asking for was kind of the same thing. I want patients to really tell me what's going on with them. I want them to feel trusted. I want to be trusted and heard when we're sharing information. I want to work collaboratively with my patients to be able to achieve a safe diagnosis. And so we identified several initiatives or activities or strategies that we could do. And what patients can do is tell their story fully, completely, and clearly, provide accurate information about their healthcare symptoms, and don't stop when you get interrupted, because that interruption is often the signal to a patient, unfortunately, that the clinician has enough information to make a clear diagnosis. So they're like, all right, my job's done. Now I get to hear about what's going wrong with me. To speak up. So if they haven't felt heard, to speak up and ask questions. Ask those clarifying questions to make sure they understand what's going on. And potentially even use a checklist, maybe of your tests, your symptoms, your concerns, or even the number of physicians or people you've consulted, information you've sought out to help clarify your need to access the healthcare system. And what clinicians can do is listen. Listen deeply, richly, effectively. Support patients in effectively sharing their symptoms. Have different ways to ask questions to patients about what they think is really going on, because oftentimes it's not the first thing they walk through the door for. Conduct a thorough history and physical examination, and set a visit agenda. Right now, with our healthcare system and the way it is, the production pressures are great. And sometimes you can't get more than one or two questions asked during an individual visit anymore. So setting and co-creating a visit agenda is a great strategy for clinicians and patients both to set expectations of what we can and what we cannot accomplish at one single visit. Another key piece is to know the patients. Make sure you read up on the patients. Make sure you read to understand the information that they've already collected in that pre-work. So that's pre-labs, having blood work done, making sure that any tests or anything else is available to you so you can have a really rich conversation about that diagnosis. And at the heart of this is reflective listening and reflective communication for both the patient and the clinician. Next slide, please. So we developed two strategies, and these strategies are paired. They're paired on the patient side, so we never want to give a patient work to do in the healthcare system without giving the clinicians the tools to respond to it. Because what that signals to a patient, if they fill in a note sheet or they fill in some information in the clinic or the practice, and they never hear their clinician validate the information or share it or let us know how important that information is to a really good, rich clinical relationship, then patients devalue it. So the paired tool approach we looked at helping patients be prepared. So be prepared for their visit, to share their story, to ask their questions, and to tell the clinician what they've done up until this point to get them into the encounter room or the hospital setting or the emergency department. So what they've done, their patient's work before coming in to the hospital or to the encounter. And on the clinician side, we have the 60 seconds to improve diagnostic safety. And I think my colleague Hardeep had mentioned that is the 60 seconds of wisdom, 60 seconds of a diagnostic pause, 60 seconds to create a relationship. So what we're doing is asking clinicians to give that first 60 seconds of the visit to the patient to share their story clearly. And we've prepared them to do so with the Be the Expert on You note sheet. So together, these couple to create a rich, dynamic, collaborative diagnostic encounter. Next slide, please. So I'm first going to talk about the Be the Expert on You note sheet. This was developed and co-designed with many engaged members of our team, including patients and family members, clinicians representing the depth and breadth of our healthcare system, as well as individual experts in diagnosis, communication, health equity, and human factors. So that was really important, the human factors, and we had a designer as well. So what it starts out with is asking some big probing questions. Why are you here today? What brings you in? And our patient partners asked for check boxes because there are some things that are almost routine, things that they're doing every day. And so a checkbox made sense. So they could just check something off rather than having to write it down. Another big question was, has there been a change? What has changed over the last few days, either in your own diagnosis or chronic disease that you already have, or something new that's completely different from what you've experienced before? And how have you been feeling, and how long has it been happening? And these questions that are part of the Be the Expert on You note sheet, they're actually part of a structured way we teach clinicians and how to think about the information that they're bringing in and how to retain it and sort of compartmentalize it. So it's building off of some of the things we use in medical education to teach our clinicians how to be clinicians. What we also have is some questions. What do you have questions about? Are they about your medicines? Are they about your work, your tests, your treatments? Is something that something else that you want to talk about? And so individual patients can check that off, or they can use this as a prompt. And the most important question at the bottom here comes from the National Academies of Science, Engineering, and Medicine's report about what are you most worried about? What else could this be? And that's really where we found a lot of value in this particular strategy. And it's important to have your staff and your other team members be aware of this particular strategy because they're really facing the first person to interface with the patient. So maybe if you're coming into a primary care visit at your clinic, you might be able to pick up one of these, fill it in before your encounter or while you're waiting in the waiting room, and then go into your encounter and be ready for your appointment. Other individuals have sent this via telehealth, so they send it or email it out to their patients before a telehealth encounter so that the patient's ready to share the information in a way that clinicians can understand. So together, this is the first part of that paired tool strategy, preparing the patient for the encounter. Next slide, please. The next part of it is the 60 seconds to improve diagnostic safety. And I'll have to say, when we were developing this and talking to clinicians got a little nervous about this. As we all know, our physicians right now, particularly in primary care, but really across the healthcare system, are time pressed. We have about 5 to 10 minutes to come in, create a relationship, sit down with our patient partners, and partner to really figure out what's going on and what's most important. What do I need to prioritize as a doctor or a nurse practitioner in this visit? And so when we said, we'd like you to try giving the patient the first 60 seconds of your visit to tell their story without interruption, just be silent, invite them in and listen and sit down and really, really deeply listen. It was a little scary at first, but once we had clinicians who were trying this, they absolutely loved it. They had that pause. They were able to take a minute and just sit and reflect and look at their patient, be able to sit eye to eye, listening deeply, hearing and seeing what was going on with the patient. So really not wrapped up in the electronic record, making eye contact, being visible to the patient, making the patient feel heard and seen. And what we learned was patients were very receptive to this. And at the end of the day, even though we had 60 seconds or asked them to be quiet for 60 seconds and reflect for 60 seconds, patients really only took 20 seconds to maybe 30 seconds to tell their whole story. So it really was this effective, deep listening, rich opportunity to share information. Next slide, please. So in the 60 seconds to improve diagnostic safety, what's going on with the clinician is they're bringing in all that pre-work, all that information that they know about the patient, their history, all the things they've read in the medical record. And then it allows the patient to share their story so that the gears start working. And when we asked our clinicians, what do you need? What do you need from us to help you in that 60 seconds? They said, we need something to do. And so we created this ask, listen, and act. It's a reflective practice exercise that anyone can do. You ask a question, so you ask a big open-ended question. So, what brings you in today? How can I help you? Asking questions to help open up the relationship, open up that dialogue. Listen carefully so that then you sit back and have your 60 seconds of reflective practice. You listen deeply, you think about the information in context with everything else, and then you ask follow-up questions after the patient is done. And that sort of break between listening to the patient and then asking them once they've finished their story really demonstrates to the patient that you've listened deeply and they've been heard. It also allows time for that clinical calibration to happen. So our clinicians who participated in our pilot study really felt they were heard and listened to when we had all of these tools and suggestions for them. Next slide, please. So you get started with this by really just asking what brings you in today, actively listening, and then acting on the information that's shared, co-creating a care plan together to understand when patients need to know how to come back, when to come back, and setting expectations for the next period. Next slide, please. So the toolkit itself has several strategies and pieces to it. We have a toolkit implementation roadmap, which is on the Agency for Healthcare Research and Quality's website, which I see somebody has put into the chat. Thank you very much for that. And this roadmap will really help anyone get started. It is a deceptively simple tool, and I do keep saying that because we heard it over and over again in our pilot test. Next slide, please. There are also some planning worksheets that give you step-by-step guidance on how to go through step 1 to step 5, which helps you bring together all of that information and really plan a locally tailored implementation to your context, whether that be a clinic or a hospital. Next slide, please. There are training materials as well as part of the toolkit to help you get started, and slides and other scripts. These are identified where you need to tailor them as well. So it really does help you get started very, very quickly. Next slide, please. There's also some sample workflows, which people wanted to, which our people in our pilot test really wanted to make sure others had the opportunity to have. And we have one for telehealth and one for in-person. Next slide, please. And then finally, we learned a lot during our pilot test. We tested this in over 24 practices across the United States. And we heard from patients that, between 80 and 95% of patients felt improved communication. Clinicians really felt heard and felt the joy and meaning of healing back. So thank you. I'm going to hand it back to Fran to take us to the next speaker.
Great. Thanks so much, Kelly. Really interesting material there, and I'm sure we'll be coming back to it during the Q&A. At this time, we're going to hear some more, though, from Dr. Singh.
Hello. Thank you for inviting us. My colleague Annie Bradford had a family emergency and could not join us today, so it'll just be me. Let's go to the next slide. So why are we here? And what makes the case for a learning health system for diagnostic safety? I hope this picture sort of sends the message. Essentially, this is a foundation for improvement. If we can create a learning health system where we can do some sort of initiative to learn and improve, do a risk assessment, and then follow that up with gathering and analyzing our missed opportunities, we can take actions to change practice. In this learning health system, you really need to involve everybody: clinicians, patients, policymakers, health systems, caregivers. This is essentially the foundation of what I'm going to tell you in the next 10 minutes. Next slide. So how do you do a risk assessment? So if you're a healthcare organization, how can you assess that you're really doing a good job or not as far as diagnostic safety is concerned? So here's a tool that we developed, which is actually on the IHI website, which helps you walk through your own health system's performance as far as diagnosis is concerned. It's freely available. It's only 4 pages long, which makes it hopefully very feasible to do. It involves a team of people, and if you go to the next slide, it sort of gives you some instructions on how to get together these team of people who can do this assessment. There are 10 items on this checklist, and essentially you score yourself and you figure out, have you implemented these practices in your organization? So again, it could be an eye-opener for any organization trying to rate itself or figure out where are the improvement areas. So that's how you do a proactive risk assessment for diagnosis. Next slide. Now, the next topic is that for MeasureDX. This is a tool that we developed with AHRQ funding. In 2022, it was grounded in an evidence brief or state of the science brief that we also published it's actually also on the AHRQ website. And we asked a lot of national experts about what to do in measurement related to diagnostic safety. This is, again, a freely available tool which can help healthcare organizations identify and learn from diagnostic safety events. Essentially, what we did was we converted all the research that has been done in this area and translated that into things that health systems should be doing as far as measuring and learning from diagnostic safety. Next slide. So here's a quick overview of what this tool looks like. Essentially, there's 4 big steps, and I'll walk you quickly through each of those. First, you prepare for measurement. This is when you get your team together. The key stakeholders you can imagine are quality and safety, your healthcare leadership, the clinicians, patients, as well as informatics, and anybody you think could be important for this initiative. You get your team together. The other thing is important is to fostering psychological safety. Clinicians often feel a little threatened about the topic of diagnostic errors. They get nervous around it. And again, creating psychological safety to engage clinicians is really important for this initiative to succeed. The second thing is to do some sort of a risk assessment. So we recommend the SafeDX tool, but MeasureDX also has a self-assessment on how is your organization doing? What kind of resources do you have? What kind of strategies can you use for learning and improvement? How will you gather those cases or near misses or safety events that can help you learn and improve? The third step is implementing one of those measurement strategies. So in this tool, we recommend 4 measurement strategies, and you can use 1 or more. The first one is what existing quality and safety data you already collect, whether they are malpractice claims, root cause analysis data, autopsies, any quality and safety data that you're already using. The second one is clinician reports. So as most people can realize, clinicians have a lot of knowledge about missed and delayed diagnosis from not only their own patients, but also those of other colleagues. They could report these things. The third is patient reports, patient-reported data, whether it's from patient complaints or data which is coming in from other sort of patient experience surveys. Oftentimes, some of these surveys have very rich qualitative data that you can harvest for learning and improvement. And lastly, your electronic health record data. So what kind of electronic health record system do you have? Can you use some type of flags to identify high-risk patients? And we've used these electronic triggers before, and we walk you through how to identify some of these high-risk patients who may have had a diagnostic error in their journey. And then lastly, you review and analyze cases. We offer tools that are useful for a healthcare system, a healthcare organization, the quality and safety teams to use to look at the information that is available in the medical record to identify what happened and then act on it. Next slide. So in our evaluation that we just recently completed, we enrolled 11 health systems to participate with us on this collaborative, if you will, where we studied how did they implement Measure DX within their organization. How did they do the case finding? What did they find as most useful? And as you can see, every one of them used one strategy, one or more strategies. A lot of the cases came from electronic health record enhanced chart reviews. So they were using some type of electronic trigger to flag those records. There was cases from existing quality and safety data. And then they did record reviews to identify learning opportunities. And they found about 703 learning opportunities where they thought that there could be something useful which could be done within their organizations. Next slide. And just, by the way, when you look at the tool, there are a lot of resources that I'm not showing which are linked within Measure DX. So how do you do a case review? So one of the tools that we've used is the Revise Safer DX instruments. We walk you through how to do a case analysis for diagnostic error or a missed opportunity or a learning opportunity through some of these case reviews. So they're very rich case reviews, and you do need clinical input to do that. So in our implementation, sort of this assessment, we also try to figure out what did teams learn while they were implementing Measure DX at their organizations. They found many types of diagnostic safety concerns, several types of errors. Some of this would be familiar to you. In fact, somebody already sort of put in this delayed communication of test results, missed follow-ups, oftentimes arise quite frequently, no matter which health system you look. Based on what they did, they took a lot of actions. Some of it was building better clinical care pathways. Some of it was providing feedback to clinicians. Some of it was escalated to leadership for additional action and resources. So there was a lot of actions that were taken because there's no point in having a learning health system unless you act upon the data that you're collecting. So Measure DX is the start of your journey where you start collecting data and you start evaluating and looking at the data, and then you have to act on the data. So the action is really, really important. Next slide. So, next slide. Yep. So what were some recommendations from participants? So a lot of people felt that this is a new area for them. It's quite complex. There's a lot of new concepts involved, and it feels overwhelming. So one of the recommendations was start small. One of the things we always tell people is, what is your highest priority? What are the most common types of problems that you are facing? Let's assume, given the example of missed follow-up of test results, maybe you want to have a focused project only on that. So looking at some cases and doing something on that. So don't try to like boil the ocean at one time, but start small, get some early wins so you can get more resources for your initiative. Next slide. Leadership. This comes up time and again as far as diagnostic safety is concerned. As most of you know, there is no regulation around diagnostic safety. There's no policy requirement yet on diagnostic safety. So most of this is intrinsically motivated healthcare organizations that are trying to do something on diagnostic safety and diagnostic excellence. So engaging leadership so you can get your resources is really important, whether those resources are for your data analytics to get the electronic health record data out, or is it for your quality and safety team that needs to be enriched with some clinicians who can do some case reviews, or it's engaging clinicians so that they can participate in some type of diagnostic error reduction activity. Clinicians often need protected time, and all that comes from leadership to do what needs to be done for diagnostic safety. So again, very important to engage leadership. Next slide. Work with what you have. So some of you may have a robust electronic health record that can give you longitudinal data for diagnostic safety. So diagnosis is an evolving process. It unfolds over time. Patients go between different settings of care, whether it's emergency rooms, primary care, hospitals. And so really to map their journey, you need a robust electronic health record where you can get the data out, you can study the data and identify what happened to these patients. So you do need some data analytic capabilities to identify what's happening to these patients. You also may not have that, but you have clinicians who can report. If you make it psychologically safe for clinicians, if you make it easy for clinicians to report diagnostic errors, they will start letting you know when these things happen. You may not have all of that, but you may have patients, you may have patient complaints and patient surveys where they are putting in some information for you to leverage and figure out how can you improve diagnostic safety. So work with what you have. And again, this may be one or more strategies depending on what kind of data systems you have, but all healthcare organizations can do something useful based on any of those data sources that I mentioned. And next slide. So here are the links for these tools. Again, they are freely available. There's a tons more on the AHRQ website we would encourage you to look at. Thank you very much for listening, and back to you, Brent. Thanks.
Great, thank you so much, Hardy. It was really interesting thinking about the intersections between everything you talked about and some of our basic principles in quality improvement about starting small and working with what we have. And I'm sure that people will see the intersections there. So we have one more presenter to go, and then we will open this up for Q&A. So it is my pleasure at this time to introduce Dr. Sangeeta Ahluwalia, a senior health policy researcher at the RAND Corporation, who leads research in the areas of end-of-life care and diagnostic safety. She is co-principal investigator of a 4-year AHRQ-funded initiative to implement and evaluate diagnostic safety resources in healthcare sites across the country. Dr. Ahluwalia received her PhD in health policy and master's degrees in public health and political science. So Dr. Ahluwalia, over to you.
Thanks, everybody. Sorry that it took me a little bit of time. Thank you so much for having me here on this really important day. I just have a few minutes of presentation and then we can open up for Q&A. So now that you've learned about a couple of these very important resources that have been developed by AHRQ and are available to you to advance diagnostic safety, I'm pleased to talk about this initiative that I hope you'll consider participating in. RAND is leading the IDEAS project, which is an AHRQ-funded national effort to support and evaluate healthcare organizations as they implement and test one or more of 3 diagnostic safety resources, including Toolkit or Patient DX, as Dr. Smith noted, and Measure DX, as Hardeep Singh just talked about. Next slide. The IDEAS project is designed to support diagnostic safety across different types of healthcare settings and targets different users of these resources. So as we heard, Patient DX, or the toolkit, aims to help clinicians and their patients engage in improved communication to support diagnostic safety in office and other clinic-based settings. Measure DX, which is designed for QI or patient safety teams in really any healthcare setting, aims to help sites use data that they already collect to identify diagnostic safety events and learn what systems and processes could be improved. And Calibrate DX seeks to improve individual clinicians' diagnostic decision-making through self-evaluation and review of their own cases in any healthcare setting. Next slide. So we are currently recruiting sites who are interested in participating in this initiative. We will begin implementation of these tools at your sites with training and support provided by our team, starting on a staggered timeline with Toolkit for Patient Engagement in March of 2025, followed in June by Measure DX, and finally August with Calibrate DX. Here are some resource-specific considerations if you're thinking about participating and testing one or more of these tools. For the toolkit for patient engagement, we're looking for sites to contribute 2 to 3 clinician participants to use the resource in their practice, who can participate in brief data collection activities for our evaluation, And you may need to involve administrative staff to help collect brief anonymous patient surveys as part of site participation. For Measure DX, we are looking for QI and patient safety teams, ideally teams that have both a clinical lead with diagnostic expertise as well as a quality manager with operations expertise. This team will also need to participate in brief data collection activities. We've designed them for Measure DX to be done during existing QI meetings or other scheduled activities, team activities to minimize burden. And then finally, for Calibrate DX, we're looking for 4 to 6 clinician participants at each site. Those participants should be able to perform quarterly reviews of their own cases using the 4-step Calibrate DX process that we just heard about. As part of the tool, there are some brief quarterly surveys to provide feedback, and clinicians will need to be able to access clinical record or EMR data so that they can identify and review their cases. Next slide. So why should we participate? First, this is an opportunity to improve care, obviously to minimize risk of harm by implementing some innovative tools to improve diagnostic safety. But even better, it's an opportunity to implement any or all of these resources with tailored support from us, from the RAND team, and from our partners, IHI and Convergence Health. Convergence Health specifically focusing on supporting rural sites who would like to participate. Our support includes training on the specific resource, CE credits, ABMS approved MOC credits, tailored technical assistance and hands-on help, including a dedicated email for questions. We'll hold office hours with content experts. We're putting together learning collaboratives with other participants that you could participate in as needed throughout the implementation phase of this study. We'll also provide feedback at the end of the study on what the impact of the intervention has been based on the data that we've collected. So we'll provide that back to each site. And then finally, there's a modest stipend to recognize your site's participation in this AHRQ effort. So if you're interested, please email us at ideasproject@rand.org. That's ideasproject@rand.org. Case doesn't matter. And I believe that is in the chat as well. So that's it for me. Thank you for your time, and I will hand it back off.
Sanjita, and great presentations from all three. And I think one of our nice common themes here, all are very practical and could be used tomorrow in many places, which is great. So we're going to open it up now for questions and comments from all of you. And I invite all three of our speakers to come back onto camera for this portion of the discussion. And we welcome anyone with a question to please put it into the chat at this time, or if we are able to do it, we could take some raised hands and unmute some microphones. What we're really interested in hearing as well from the question we posed to all of you is, what are you thinking about? What diagnostic errors are you working on now? And what questions or comments do you have for the speakers? So let me just check the chat and see if we have any. We've got a lot of great links in the chat at this point in time. No questions yet. I have a few in mind while we're waiting for people to get out on the dance floor here. So I want to go back first, Kelly, to what you were talking about, particularly that 60 seconds to improve. I like that because I know that so many times when we talk about strategies, people are concerned, as you mentioned, with, I don't have enough time to do what's on my plate now, and now you're asking me to do it. There's always that perception it's going to take time that I don't have. So 60 seconds, I think, would make it feel very doable for many people. I think I heard you mention that it was mostly in the primary care setting where you've been looking at this and working on it. It seems like it would be applicable everywhere, though, that patient conversations are happening. Has it been applied more broadly in the inpatient setting with specialties?
It's a really great question, Fran, and I can say yes. In our pilot study that we did during the development and co-design of the work, we had practices everywhere. We had outpatient practices, we had surgeon offices adopt it, we had specialty outpatient clinics. And a few of our resident physician practices, our large resident physician practices, actually took the tool from their ambulatory clinics and brought it into the hospital. So we did get it tested in the hospital and had a lot of great feedback. One of our resident physicians talked about how they were really struggling to get a diagnosis for a particular older lady who had been in the hospital for 7 days and still didn't have a diagnosis on their problem list. And so she sat down with the patient, filled in the be prepared, be the expert on you, had the patient share their entire story. And it actually changed the trajectory of care for that individual. She was able to get a diagnosis within the next 24 hours and be discharged from the hospital safely. So it has been tested in a lot of different practices. We had individual rural practices, we had visiting nurses and mobile clinics in inner city Washington, D.C. and Baltimore tested as well. So it's been, the tires were kicked pretty well. And we had a lot of feedback, which resulted in improvements to the toolkit, which is now what is represented on the AHRQ website.
That's a really great story to hear how it was brought into the inpatient setting and used in that particular case. And it actually ties to another thought I had as all three of you were presenting. In our webinar last month, we heard a lot about safety competencies, including training that one colleague is doing for medical students. And as I was listening to all of this, I thought, gosh, this is the type of stuff we should be teaching to medical students and nursing students and all kind of clinical students as well, to get them this type of resource early on when they're first learning how to do diagnoses and using the various diagnostic tools. So great to hear that a resident was proactive with one. We do have our first question in the chat from Richard Travers, and his question is, how do you address radiology delay reads which affect ED throughput? Not sure which one of you might want to tackle that question.
I can take that or try. So I think it depends on what the reasons for the delay is. So do you have a on-site radiologist, or is your radiologist sitting in a different continent or a different state who is reading your radiology reports? I think this is why a workflow analysis is essential to figure out what the point of the delay is. There's been several sort of workflow analysis models, figuring out, it's almost like the lab where there's a turnaround time, what's the radiology turnaround time and why. There are some solutions that I can think of, that are helpful. So I'll mention that one of the ones is if the radiologist has about, 100 reports to read before the one that you really want to get read, but the one you want to get read is possibly abnormal or has a bleed. There are many places now using artificial intelligence to up triage the report. So the radiologist now doesn't have 200, but is like right next on the list. So it'll bring it up to number one for the radiologist to read right away because the AI has already detected this, something is abnormal. So some health systems are doing that. But again, I would suggest a detailed workflow analysis to figure out what the problem is so you can solve it effectively.
Great, thanks. And I see, Sanjita, that you added to the chat that residents are welcome in the Ideas Project. So that is great. So that would be residency programs could apply as well?
Yep, absolutely.
Okay, yeah, that would be great. It's so important to help people learn these skills and resources early in their training rather than trying to retrain people after they graduate, which is what we've been doing for the many decades that this work has been going on. Going back, let me see, I don't see any other questions yet in the chat. I'll keep watching for that. If anybody has a question or anything you'd like one of our speakers to elaborate on further, please do put it into the chat. I do want to go back, actually, Hardeep, to some of the things that you talked about. I thought it was really great that so much of what you talked about didn't require somebody to go out and spend a whole lot more money, get new resources. It focused so much on using what you have and the data. And I'm curious, in the learning for the folks who've worked on this so far, how was confirmation bias addressed? Did that come up with any of these diagnostic errors? is we know it's such a common problem, especially with the human brain and the way we all think, that confirmation bias can be such a challenge in diagnostic error. Did that come up in any of the analyses that any of the participants did in looking at their own events and reports?
So in this project, we specifically did not get data from the sites. All the sites did their own analysis and figured out. But given the basis of the question and the fact that we've analyzed thousands of these often will come up. All kinds of, cognitive or reasoning types of issues come up. My colleague Mark Graber just recently published sort of how to do a root cause analysis, for diagnosis. I'll try to find it and put it in the chat that some of you might find useful. Again, a lot of these things are interaction between the system and the cognition. And oftentimes it's not just like a single bias or a single cognitive error that is causing the problem. But although, when you do a root cause analysis or you do any kind of safety analysis, you find multiple points of breakdown. It's often not just one single clinician or one single physician who, may have had one bias. It's like a multitude of problems that have happened over time. And a lot of the things that are fixable often come to the system issues that are causing this to be a problem.
Yeah, that's so true. That's why many of us stopped calling it root cause analysis years ago and call it root causes analysis, because that silver bullet answer tends to never be there. I can't help but reflect on, I've been reading about AI in medicine in particular, and sometimes I think AI will help us in these areas, and sometimes I think it has also the potential to add another layer of error, especially with the hallucinatory events that we see in some of the AI software. We do have, thank you, Kelly, for putting in the link that Hardeep mentioned, and we have a comment and question from John Harrington in the chat. Residents and medical students with less PE and diagnostic skills experience are being deployed in ED and urgent care settings, and supervising physicians provide praise for efficiency and speed and likely shortcuts that lead to level 1 thinking. How do we guard against that? Kelly, I see you smiling. Would you like to start on that one?
I have a policy perspective on that, because part of the challenge is that all of our healthcare system is under stress. It's under more stress than it's ever been. And this is a twofold solution. One is education and training, and how we educate and train our clinicians is really critical in this. But really the policies around the 10-minute visit, or the production pressure for a 10-minute visit, or the seeing 20 to 30 patients a day in a primary care or urgent care setting need to be relooked at, because given the volume of information we now have in the electronic health record, coupled with sort of the learnings that are coming in from the patient, that can't happen in a 10-minute visit. And so part of this is policy at a larger level to enhance training and education, as well as the payment mandates around that sort of force function, this production pressure that clinicians are under in every single setting, not only the emergency department or urgent care, but those are solutions. Urgent care and ED are seeing that because the primary care system is fragmented and broken right now across the world. But in terms of direct clinician, I'm going to hand it off to Hardeep to talk about that individual clinician part.
Yeah, this is a big problem. I mean, this is a multiple issues. This is not just a single clinician. Firstly, our training and education, like Kelly mentioned, I mean, we're not emphasizing history taking and physical exam anymore, because we think AI or other electronic systems is going to solve the problem, which is not true. So the basic clinical skills of listening to the patient, which is what Kelly was trying to emphasize all along, is one of the single best hallmarks of how you can get the diagnosis right. People don't listen anymore, and we're not spending time with patients. But there's multiple reasons. If you have a ER where there's already boarded patients, There's people in the hallways. I mean, there's so much overcrowding and such staffing shortage, you can't take care of patients. So this is a system problem, and I think a lot of the solutions are policy, should be policy focused, like Kelly mentioned. But again, bringing it back to sort of what we talked about, which is sort of measurement. Well, it's a perfect opportunity to implement a system of measurement, because you'll start finding there's a whole lot of your return visits that were unscheduled, which is what we sort of, one of our triggers is based on if you have a ED visit and then if you return within 7 to 10 days unexpectedly and you get hospitalized, we do a look back to see, was there a diagnostic error? So we have it's called an electronic trigger for an ED return visits. And we'll hopefully be publishing some data on it pretty soon. But when you start implementing a measurement system, you'll find, oh, a lot of these patients actually don't have a physical exam documented. A lot of these patients don't have any history documented. So when you start looking at the medical records through the lens of diagnostic safety learning opportunities, you tend to find a lot of these fixable things, which could be good feedback for the resident or the ED chief, saying, here's a lot of patients who were hospitalized with a diagnostic error, a week before, and in the ED because we had no physical exam done, or we were not sort of thinking about these issues. So there's a lot of ways you can approach that through the measurement lens, because measurement is itself one of the single best interventions as far as diagnostic safety.
It's great. I think that's a great way for us to wrap up this portion of the discussion, because it really is all about learning, and that type of measurement can really help us learn where the opportunities are. So thank you again to all three of you. This was a really interesting presentation set today, as well as some good discussion, and there's some great practical resources in all three of your materials that people could start using right away. So with that, we've just got a few things as we wrap up. So we are still looking for feedback from all of you in the chat. We'd like to know, what are the top priority diagnostic errors in your organization? It would help us to know more about what you're working on and help plan for the future. So if you have a moment before we end the webinar, if you could please type that into the chat, that would be great. We also want to mention some upcoming events of interest before we adjourn. So the first is a webinar hosted by the Leapfrog group, also on diagnostics. So this one is around achieving diagnostic excellence on October 18th at 1 p.m. Eastern Time, a 3-part presentation on diagnostic excellence. You can see the speakers are listed on the slide, and the registration link is available in the slide deck as well. And perhaps we could drop that registration link into the chat for people as another layer for them to be able to access it. We also want to emphasize our next monthly webinar for the National Action Alliance coming up in October. This is actually going to be the first in a series of 3, as we really are going to dive deeply into the workforce safety aspect of this, because we know a safe workforce can help support patient safety. So this will be the first in 3 webinars starting on October 8th, focused on leadership strategies that improve workforce safety and well-being. And I can tell you that the speakers that are lined up for these 3 webinars are truly outstanding and great thought leaders who've applied many of the strategies that you're going to hear about. So highly encourage you to register early for the webinar on October 8th. The link is here in the slide. It's available on the National Action Alliance website as well. And you can continue to stay connected with us in between the monthly webinars by subscribing to the NAA Listserv monthly bulletin, or sending an email at any time to the email address you see at the bottom of the slide, nationalactionalliance@hhs.gov. So we look forward to seeing all of you again next month as we dive into workforce safety, either live or in the recording. Thank you again to our speakers today, and for everyone in joining us on World Patient Safety Day. Congratulations on what you've accomplished, and keep the ambition and the momentum going as we continue to work to make the environment of healthcare safer for patients and our workers. Thank you, everyone. Have a great day.